Okay, in this video, we will be discussing about the NEET PG 2023 medicine questions, medicine recall questions, right? I have divided the total number of questions, which are almost 30, which somehow relate to medicine. Some are totally from the medicine. Some have an overlap between medicine and other subjects like microbiology and pathology, etc. So I have divided the questions into different categories. Like a few are easy, there are regular, I mean normal questions, normal difficulty. Then there are very hard questions also, which require a next level understanding. Then there are a few rank determining questions, right? Hard are like the questions which are not, which cannot be answered by many, but rank determining are those which will be answered by a few of the students only. uh, I mean those who will rank better. And there are few integrated topics which pertain to microbiology, pathology, and pharmacology, a kind of overlap between these questions. So starting with the easy ones, excuse me, starting with the easy ones, we have the first question in here. Says 78 years old woman, progressive decline in daily activity, history of convulsions, and stares off into space with frequent visual hallucinations, right? Frequent visual hallucinations, very important. Lewy body with neurons is the pathology, right? Now we know that if there is Lewy body disease, it is a kind of pathological diagnosis, right? It is a pathology we see under the microscopy. Lewy bodies, it is seen in Parkinson disease with dementia. I mean Parkinsonism patients, for example, a patient is having Parkinson disease from last 10 years, and now he is having features of dementia. One of the ends of spectrum is PDD, Parkinson disease with dementia, and the underlying pathology is Lewy body pathology. Second variant can be dementia with Lewy bodies, DLB, right? DLB is also similar. There is Parkinson like features, there is visual hallucinations, fluctuation of attention, episodic memory is preserved, the other memories are lost, right? And this is this is also a uh, this is also the underlying pathology in this is Lewy bodies. So in DLB, the difference between PDD and DLB is that DLB the dementia is a earlier feature. Dementia is earlier feature, and PDD dementia is a late feature, late onset dementia. I mean the difference between motor symptoms and dementia is more than 1 month, 1 year, or 12 months, right? Here dementia occurs early, the motor symptoms appear late. So this is basically either Parkinsonism or it is DLB in itself. According to the questions, according to the options, we have these three options cannot be there. Only Parkinson's disease. It is a kind of easy question. I mean, if the option would have been DLB also, so that would have been a more trickier question. So in this case, Parkinson's disease, it is very straightforward kind of question. Only one option, one relevant option is given, that is Parkinson's disease. Hallucinations and memory loss, it is Parkinson's disease or DLB, but in this case, obviously Parkinson's disease. Second question, it says कि 40 years old female, chest pain, palpitation, shortness of breath, MDM, mid diastolic murmur was heard, and a prominent A wave on JVP. And the options are either MS or or TS, right? Prominent A wave on JVP means there has to be either MS or there has to be TS. Though TR can also be there, MR can also be there, but in these cases the murmur is basically systolic. In these cases the murmur is diastolic, but you see it has to be tricuspid, because what happens in tricuspid, in early stages only you will see elevated JVP and prominent A wave. But in mitral stenosis, first of all, the patient will develop portal hypertension, then he will develop right ventricular hypertrophy, then he will develop tricuspid regurgitation, will be functional, then he will develop raised JVP and prominent A waves. So it is a very late feature in mitral stenosis. Tricuspid stenosis is a better option there. Right. So this is the answer to this question. Third question is a male patient having multiple sexual partners had tested positive for HBs antigen and HBe antigen. Treatment protocol. We know that HBs antigen is the marker of infection. The patient has infection. He has hepatitis B virus inside his body. HBe antigen is a marker of infectivity. It means if the patient is having HBe antigen, he can transmit the virus to the other person. It is a marker of infectivity, right? So they are basically asking the treatment is, see, these peg interferon alpha, lamivudine, peg interferon alpha alone, lamivudine alone, these are not the, I mean, preferred treatments. Although, I mean, theoretically they work, they have efficiency, they have we have studies pertaining to them also, but practically we do not use them. We use either entecavir or we use tenofovir. Right? Tenofovir is used more commonly than entecavir. Initially we used to use tenofovir, tenofovir disproportional fumarate, but nowadays what we have a better alternative, tenofovir alpha, alafenamide. It has decreased renal toxicity. The dosage is also different. It comes in 300 mg tablet, it comes in 25 mg tablet. So it is a very potent with less side effects, and it has decreased renal toxicity. So this is obviously a better drug. Tenofovir is the option in here. Regarding durations, actually we treat the patient for lifelong if E antigen is negative, because we do not know when to stop the treatment. If the patient is E antigen positive, then we can give the patient a 48 weeks course. So more than 48 weeks, for 40 weeks, which is the option, it is very, right to mark this tenofovir as the answer. Next question is kind of tough. It is on dialysis disequilibrium syndrome. Dialysis disequilibrium syndrome, in which there is rapid transfer of urea into the dialysate. I mean, the patient's blood is kind of hypertonic before the transfer of urea into the dialysate. I mean, before the filtration. So there is a basically kind of osmotic balance uh, inside the blood of the patient. But when urea moves out of the blood into the dialysate at the time of dialysis, the blood becomes hypotonic. Hypotonic means there is more water and less urea. If there is more water, what will happen? If there is more water outside the cell, the water will move inside. It will cause swelling of the cells will swell up, and it will cause raised ICT. And they are saying ki what is the treatment for the condition. Treatment is obviously mannitol, because the patient will exhibit the signs and symptoms of raised ICT. Next, it is a kind of rank determining question. It says that 23-year-old medical student, 2 months history of palpitations, sweating, restlessness, sweaty palm. Clinical findings are depicted in the image. Let us see the image. Image gives us this Dalrymple sign. Frightened and scaring look. Upper lid retraction. Right, it is the Dalrymple sign. So The diagnostic finding. What is the diagnostic finding? I mean, how will you diagnose the patient? What investigation will you do? If we suspect the patient to be of Graves' disease, what we do? We do TRABs, TSH receptor antibodies. These are of two types. One are the blocking types, the other are the stimulating types. The stimulating types are found in Graves' disease. Blocking types are found in Hashimoto. Right. So we have to check the levels of antibodies, anti-thyroid receptor or anti-TSH receptor antibodies, or we call them as TRABs in short form. So that is the answer, thyroid receptor antibody. It is a kind of easier, but it is you require a certain uh, underlying knowledge, the image, basically the image, because you have to see the sign and you will solve the question by looking at the image itself. Another question is that a patient who is a known case of hypertension, he is on multiple antihypertensive drugs. Given ECG findings, which drug is the causative? In ECG, we have been given these tall T waves. Tall T waves are very easy to see on a typical ECG. You will just look at the ECG and you can tell the T waves are tall. What is the causative drug? The options are spironolactone, hydrochlorothiazide, propranolol, losartan. Right? Losartan, propranolol, hydrochlorothiazide. Losartan causes hyperkalemia. Propranolol causes hyperkalemia. Spironolactone causes hyperkalemia. Hydrochlorothiazide causes hypokalemia. Right? Understood. But if a patient comes to you and you prescribe him or her the antihypertensive drug, what will you prescribe? You cannot prescribe this propranolol. This cannot be the answer. Though you prescribe losartan and you prescribe spironolactone, which drug causes hyperkalemia more often? It is obviously spironolactone. But because you have three options which cause hyperkalemia, it is a tricky question. That is why I have kept in rank determining question. Spironolactone, remember, it causes hyperkalemia most often as compared to others, right? Most often used for hypertension, hyperkalemia very commonly, similar to RTF4, disproportionate to degree of renal dysfunction, right? There is no renal dysfunction in patients with who are receiving spironolactone, but hyperkalemia is very, very aggressive hyperkalemia. So this is the answer. Tall T waves, you can look in here. These are the tall T waves. There is PR prolongation also. PR prolongation. The QRS is kind of very wide and bizarre. This is the QRS, kind of very wide and bizarre. Here deep S waves. So you have to look at the T waves. T waves are tall. Tall T waves. Answer is spironolactone. So that is the answer. Patient presents with history of uh, patient presents with sensory loss and weakness of limbs for 3 months. Angular stomatitis also, some vitamin deficiency has to be there. On examination, there is loss of proprioception. Okay, posterior column is gone, vibration is gone. UML type of lower limb weakness, upper motor neuron type lesion. Okay, absent ankle reflex sensory neuropathy. Probable diagnosis is extradural cord compression. No, there is no specification of the symptoms to one side. ALS, there has to be pure motor loss most of the times. MS, no, because the sign and symptoms are totally different. You are involved optic nerve in here. You have different nerve regions. You have uh, not proprioception vibration, but you can also have motor loss, right? You can have UMN plus MN type of element type of features. So that is it. Because of typical history and physical findings, the answer is SACD, right? Another is, this is a kind of tricky question. Chronic alcoholic patient presents with acute pain and swelling of left great toe. First metatarsophalangeal, first MTP joint. Synovial fluid analysis shows raised leukocytes. Mean this is inflammatory kind of arthritis. Right. Serum uric acid is normal diagnosis. See, this is acute attack of gout. In acute attack of gout, because the serum uric acid crystallizes, there are crystals of uh, this monourate sodium. The uric acid becomes normal. Serum uric acid levels are normalized at the time of acute attack. It is a very confusing and tricky kind of thing. Though the patient is having hyperuricemia and the patient has gout, but at the time of acute attack, the patient doesn't have, most of the time the patient's uric acid is normal. It is very misleading kind of finding, but we have to remember it. Acute gout is there, but serum uric acid levels are normal. Septic arthritis, though leukocytes are raised, but there is no history of fever, no history of infection anywhere otherwise. Pseudo gout can be there, but it involves knees and it is seen in old age. Reactive arthritis, there has to be some underlying connective tissue disease, also other connective tissue disease, right? So this is the acute gout most probably. Another is patient presents with severe restlessness, tremors, and he comes in emergency department. She comes in emergency department. Previous history of bronchial asthma. Okay. Swollen neck, some thyroid issues there. BP elevated, tachycardia noted. ECG shows AF. Okay. Which of the following drugs can be given next? Means immediately. So you have to look at the AF first of all. The thyroid will be looked after you treat AF, right? Thyroid will be looked at after you treat AF. Immediately next, what you have to do, you have to give the rate controlling drug for AF, because the patient is stable. Cardioversion is not required at this time. We have to control the rate. The patient will stabilize, the patient will become normal if the heart rate becomes normal. So AF rate control, we have three options: verapamil, metoprolol, or digoxin. These are CCBs, non-dihydropyridine types. You can give verapamil, you can give metoprolol, you can give digoxin. But digoxin is not used nowadays because it has more risk than benefit. Metoprolol can be used, verapamil can be used. Here, what is the option? We have dilsem that can be used. Profile thiouracil can be given in a thyroid storm, but this is not a thyroid storm. Even if it is a thyroid storm, we have to look at the AF first of all. After that, we will treat PTU or treat with PTU, propranolol, etc. Immediately, propranolol cannot be given because it is neither the treatment protocol and at the same time patient has bronchial asthma. So propranolol is not an option in itself, right? PTU not next. Esmolol can be given, but dilsem is better. We give metoprolol. Rank determining, another question. Penetrating cervical neck trauma piercing the lateral aspect of dorsal column tract. Dorsal column means the posterior column. Which of the following finding is seen? Ipsilateral proprioception, ipsilateral of upper limb, of lower limb, fine motor movement of fingers. I mean motor. Oh no, motor is through the anterior corticospinal tracts. Absence of contralateral proprioception of lower limb. Contralateral proprioception, no. The lesion has to be ipsilateral and the symptoms has to be ipsilateral to the lesion. Absence of ipsilateral proprioception of the, so we have to actually, here in what we have to know, we have to know the anatomy of the tracts in the spinal cord, the array or the placement of the tracts in the spinal cord in the different columns. Actually, the examiner is trying to ask you the this thing. The patient is having, we have two options here: ipsilateral proprioception of the arm, I mean proprioception. Contralateral cannot be there, we have to cross it. Fine motor movements of the fingers, absence of fine motor movements of the fingers. I mean, only fine motor movements will not be gone, the whole of the limb will be paralyzed if the lesion is anteriorly. And it is telling that the lateral aspect is involved, I mean this aspect is involved, this one. So you will be involved with these. This is the placement of tracts in the posterior column: spinal, lumbar, thoracic and cervical. So these two will be involved, or either these two will be involved, although this is the anterior tract, but it is telling the dorsal column tract. So dorsal column, this is gone, this can be there, but it is contralateral, we have to look the ipsilateral. So these two are the tracts which will be involved. Cervical will be involved first of all. Cervical will supply the arms. So the answer is absence of ipsilateral proprioception of the arm. That's it. Another question. They say कि pituitary tumor patient has undergone surgery and now has elevated sodium levels and urine osmolality is 100. It is less than 300, means the urine is dilute. Dilute urine plus hypernatremia, means there is free water loss. Free water loss is seen in diabetes insipidus. Because the patient has undergone surgery for pituitary tumor, it is central diabetes insipidus, right? Okay. What is the treatment? We give desmopressin or DDAVP. They have given desmopressin in these two options. If the patient has undergone surgery and the pituitary tumor has been removed, we have to treat the patient for lifelong. So this is the answer. Another question. Child was presented with cola colored urine and hypertension and puffiness of the eyes. Creat is elevated. Treatment was started but could not improve in next 3 weeks. Creatinine increased. What are the electron microscopy findings? First of all, you have to diagnose. It is a child and it is presenting with nephritic syndrome. Child with nephritic syndrome. What it can be? Acute onset. It can be, it can be anything. It can be IgA nephropathy. It can be PSGN. It can be anything, right? Okay. Because the creat has not improved, it is kind of progressive renal failure, and it is rapidly progressive renal failure because it is occurring in just 3 weeks. Rapidly progressive renal failure is there. What do you call it otherwise? RPGN, because it is glomerulonephritis. And what do you see in RPGN? You see crescents on light microscopy, right? But what do you see in electron microscopy? On electron microscopy, you will see the findings according to the etiology. Most of the times in children, PSGN causes RPGN. So this PSGN is basically, what do you see in PSGN? We see sub-epithelial deposits or camel hump deposits, lumpy bumpy deposits, right? So it is basically the electron microscopic finding of RPGN which has been asked in this question per se. So this is also a kind of very typical question. You have to first you have to diagnose what is it, whether it is nephritic or nephrotic, or what is it. Then If it is nephritic, it can be RPGN. If RPGN, what is the pathology underlying the RPGN? What do you see in RPGN under electron microscope? So it is a kind of very next level, 1, 2, 3 step question in itself. Kind of very tough kind of thing. Uh, but yes, if you know the concept, you can answer it. It is a kind of normal regular question. They say कि this is S1 and S2 systole. This is pansystolic murmur, right? Pansystolic murmur is seen in MR. This is the answer. Easy peasy. A patient is brought to the OPD by his wife complaining about restlessness, difficulty in expressing emotions, resting tremors, and rigidity. What is the possible diagnosis? And what is the part of the brain involved? Diagnosis is basically Parkinson's disease. It involves basal ganglia. This is the answer. 45-year-old male HIV positive, CD4 count is less, I mean 8 cells, complaints of persistent cough and weight loss. TB not. It can be TB, but it is not TB because TB is negative. Chest X-ray showed multiple bilateral nodular infiltrates along with skin lesions. Okay. Lung infiltrations. Skin lesions are also there. Diagnosis क्या है? Molluscum contagiosum, no. Histoplasmosis can be. HIV with TB cannot be because it is negative. Histoplasmosis, it is not because CD4 is 8. The answer is HIV until proven otherwise. HIV with disseminated cryptococcosis until proven otherwise. Regular. A young man complained of an early morning backache and stiffness. Lung expansion was less than 3 centimeter. Red eyes. What is the diagnosis? It is ankylosing spondylitis. It is easy because young man, not female but male. Early morning backache with back stiffness. It is spondyloarthritis. It is not the history of any GIT involvement is not there, or other findings of spondyloarthritis is not given. It is just back pain, back stiffness, young male. It is ankylosing spondylitis until and the options are also very straightforward. Paget's cannot be there, osteoporosis cannot be, heel TB. I mean, what is the sense of these options? It is ankylosing spondylitis. Physician prescribed a drug that reduces the synthesis of uric acid for gout. Identify the drug. It is allopurinol. Chloride levels in sweat are calculated in the diagnosis of which disease? Cystic fibrosis. Very easy. Young patient presents with large retroperitoneal hemorrhage. Also give frequent history of intermittent swelling of knees on strenuous exercise. No mucosal bleeding. It is due to deficiency. Okay, it is bleeding kind of uh, some kind of bleeding diathesis. Retroperitoneal hemorrhage and bleeding into the knees. It is hemophilia, and factor 8 and 9 are the most common ones, and they lead to this thing, uh, hemophilia. So this is hemophilia, factor 8 and 9 deficiency. Chronic smoker who worked in a cement factory for 20 years developed mesothelioma. It is due to asbestosis. Mesothelioma or lung carcinoma and occupational history of asbestos factories like cement, etc. It is asbestosis, not until proven otherwise. Regular question another. A male child is found to have mass in the jaw. Biopsy shows translocation 814. Diagnosis. Image shows, okay, star sky appearance, it is Burkitt's lymphoma. Translocation 814, right, very right. Patient is having features of DIC. Image shows or rods means AML-M3 or APML. What is the diagnosis? Image shows or rods. Okay. Acute promyelocytic leukemia was Fab classification. The equivalent of AML-M3 in WHO classification is translocation 1517. So this is APML or AML with translocation 1517. Right? We have to remember the other manifestations which are there in these kind of leukemia like AML. Some of the AML, they will cause thrombocytopenia, some of them will cause DIC, etc. So you have to understand, you have to know what are the other manifestations of these AMLs. AML transposition 1517 is APML. Child presents with intermittent jaundice and splenomegaly. History of similar complaints in brother. Peripheral smear shows spherocytes. Spherocytes, right? What is the investigation you will do? You will obviously go osmotic fragility test for hereditary spherocytosis. Peripheral smear of the elderly patient is shown below. What is the next step? What is shown in the smear? They have shown smudge cells. Smudge cells are seen in CLL, right? And what is the next step that you will do? You will try to know what is the kind of cell, right? Although these smudge cells are there, but you have to confirm the findings now. You have to confirm with immunohistochemistry or immunophenotyping. For immunophenotyping, you have to do flow cytometry. Flow cytometry. What you will see in flow cytometry? You will see CD10 negative, but CD5, 19, 20, 21, 22, 23 positive cells. Kind of very mugging kind of thing, but you can very well correlate key what is the next kind of investigation that you will do. HPE of glomerulus nephritis spike and dome pattern. Okay, glomerulus spike and dome pattern. It is none other than membranous glomerulonephritis, and it is seen in hepatitis B, hepatitis C. Hep B positive if it is MGN unproven otherwise. Identify the true statement regarding the myocardial action potential curve. Due to slow but prolonged opening of calcium ion channels, open sodium and close fast potassium channels. Phase 3 is close sodium channel and open slow potassium channel. No, this is wrong. The potassium channels are open and other channels are closed. But these are the fast potassium channels. Sodium potassium ATPase, no. Open sodium and close fast potassium channels. Uh, okay. Due to slow but prolonged opening of calcium ion channels, it causes the curve. Yes, the phase 2. So this is the answer. Phase 2 is the plateau phase. It is the curve. It is because of calcium ion channel opening. Integrated patient says that Delhi patient 3 days fever, peculiar rashes, HB less, WBC less, platelets reduced, BT prolonged, clotting time normal. Means coagulation factors are normal, but bleeding time prolonged means platelets are low. It is dengue. A boy came with fever and chills. Rapid test was positive for specific antigen HRP2 positive. It is seen in Plasmodium falciparum. Sewage worker came with complaints of abdominal pain, jaundice, conjunctival injection, and blood in urine. What is the investigation of choice? It is leptospirosis. We do MAT, which is the gold standard, microscopic agglutination test. Altered sensorium, headache, neck rigidity, and seizures. Delirium, high-grade fever, HSV encephalitis. Diagnosis can be confirmed by, okay, you have to do CSF and then you have to do PCR for HSV DNA. In a patient of malignancy, platelet counts were reduced during the previous cycle of chemotherapy. What will you give this time? Okay, if there is history of thrombocytopenia in previous cycle of chemotherapy, you have to give oprelvecin, interleukin 11 agonist. It is a kind of stimulating factor which will stimulate the platelets to grow. Angiotensin 2 synthesis and neprilysin action with two arrows at ACE and neprilysin. Which drugs inhibit both the enzyme? It is sacubitril. Yes. Sacubitril inhibits neprilysin, and ACE. Patient with previous MI and ventricular arrhythmia is on treatment since few months. He has developed fatigue, dyspnea, weight gain, developed pulmonary fibrosis. Which of the following drug causes it? Amiodarone, amiodarone, amiodarone. Amiodarone causes pulmonary fibrosis. It is used in arrhythmias after MI. So this is the answer. So that is all about these questions of NEET PG. I have tried to discuss all the questions in a very rapid manner, though these are all the very important topics. I have divided the questions into different categories for your uh, better understanding, easy understanding, and maybe you kind of maybe you analyze key which are the important topics from where the questions are coming. That is the purpose of discussing previous year questions or recall questions. That is all for this video. Thank you for your patient listening.